Okay, I'm applying a strong topical anesthetic before the laser treatment. And we're going to let it sit for about 45 minutes to an hour. That way you get nice and numb for the procedure.
So the display is user-friendly. For this procedure, I'm going to perform it with the scanner, using it at 180 microns, which is already selected. The MiXto senses the handpiece that is attached. It agrees with what I've specified. I'll elect for a density. In this particular area, I want a density of 10%. Then I can choose the size of the square, either larger or smaller. In this case, I want it as large as possible. And lastly, the index or the dwell time of the MiXto. And in this case, I'm going to choose the index of 8. That corresponds to 2.5 milliseconds. Next, I'll select a power level in watts. In this case, it's going to be 12 watts as we start on the forehead. So for fractional resurfacing using the MiXto, it's often possible not to use any local or tumescent anesthesia. It consists mainly of a topical anesthetic, something potent, usually a eutectic mixture of lidocaine or tetracaine, applied for approximately 1 hour without occlusion, and some oral medication to potentiate that effect. Typically in my practice, if the patient is medically able, I will administer an oral clonidine and perhaps an Ativan and or an oral narcotic or Percocet as preoperative treatment approximately 1 hour before we begin the procedure. So before we actually get started, we have our eye protection. We'll be wearing masks, preferably those that filter laser particulate well. We have an air evacuator, buffalo filter, and the patient's eyes are protected. What I will typically do is wait to treat around the upper and lower eyelids until the end of the procedure, and at that point I'll insert a topical anesthetic in the eye and a protective contact lens. I will not laser around the eyelids without a internal protective contact lens inserted. So let's get started. So we have the air evacuator on. I usually start from top to bottom, and then I'll do the periocular area last so that the patient has the minimal amount of time with the ocular contacts in. And so we'll start. Air evacuator will be very close, within 1 centimeter. I make sure that the handpiece remains perpendicular at all times as much as is practical, so as to maintain an even energy density. And I'll connect the squares. Maybe there'll be a small skip area between the squares, but it won't be visible because we're going to do a second pass and make sure any small skip areas are retreated. In time, if we didn't do this, you wouldn't see any line of demarcation from such small gaps, but it appears more natural to the patient if while they're healing they see very little in the way of untreated skin. So now, for the rest of the face, we want to induce some significant dermal tightening and contraction. There is some perioral volume loss that can only be partially addressed by the laser, but later we can volumize it with either a biodegradable or a Sculptra. But still, the mission here initially is to create some remarkable dermal tightening and lifting, and then we can readdress any of the deeper lines where they're present in part because of volume loss with volumizers. So now I'm going to change my setting to go to the maximum power of the MiXto, 30 watts. But we're also going to diminish the density to the lowest density, 5%. And we're going to continue at the SX of 8, the shortest pulse width, 2.5 milliseconds. So we're at the maximum fluence of 30 watts, but a very small density, a low density of 5%. We can diminish pain in this way, and additively we can do 2 or 3 passes and make it a full fractional resurfacing. Although the patient will have downtime with these settings, within 1 week they're looking pretty good. They usually start to re-epithelialize at 3 or 4 days and are fully re-epithelialized by 5 to 7. So let's do a test spot and make sure you're comfortable. How was that?
That's okay.
Sometimes with low densities, you might need to wear loops or magnification in order to see where the squares are so that you're not overlapping. It's very fast at a 5% density, which allows you to do several or 3 passes fairly quickly. And again, it reduces greatly patient discomfort. 30 watts is the maximum energy setting of the MiXto, and that maximizes the depth of penetration. So it's important to adjust the energy density accordingly, and safer to do multiple passes at lower densities than attempt to do a single pass or a few passes at higher densities. And care has to be taken. The more lateral the treatment, the more unforgiving the skin in terms of healing. So it's important to reduce energy settings or densities or passes peripherally and along the jawline. Sometimes at this energy setting, despite the 2.5 millisecond dwell time, we'll see pinpoint bleeding. And that's simply due to the depth of penetration at 30 watts. There may be some oozing from the papillary dermal vessels, and sometimes the pulse width of 2.5 milliseconds just isn't adequate to create complete hemostasis, which is absolutely fine. I usually have patients dab away the blood, but a little dried blood at the surface will exfoliate and actually provide some growth factors, so it's not essential to remove it. Pinpoint bleeding often increases post-operatively the first hour or 2 at these settings. And again, there's no concern, as it's an expected event at the depth that 30 watts penetrates to. So let's do a second pass on the upper cheek and perioral, as long as she's tolerant. Let's try to go around the mouth the second time, Irina, as long as you're... This will be a little faster than the first. So for the second pass, I'm not going to use the same angle of attack. And multiple passes, there's more pain with subsequent passes, but it's tolerable typically. Again, in a lot of areas, such as periorally, where there's volume depletion, to hit a home run, you're going to have to address the volume loss in addition. But they'll need less volumization if they first have a fractional laser procedure that tightens skin and to an extent volumizes from new collagen production. Different orientation of the square, so it improves the blending. Trying to remain perpendicular to the skin. Trying to get the maximum lifting of the high point of the cheek, which typically heals quickly. Okay, let's do the other cheek. You're doing very well. This is always a sensitive area for you. We're almost done. Okay, and then a touch-up third pass in the areas of maximal rhytids. Perioral area will heal very quickly, so it can be a bit more aggressive. Okay. I'm going to reduce the fluence for the lower jawline to curl underneath. So I'm going to maintain my 180 micron, my 5%, but I'm going to reduce energy to 12 watts from our previous 30 watts. I'm just really airbrushing to ensure there's no line of demarcation, but generally there will only be a temporary line of erythema where you start and stop. You don't usually see any lines of demarcation unless you're dealing with significantly ashy or dyschromic skin, and then extra care is necessary to ensure that you blend into the neck, upper neck area, or treat the neck with the MiXto, or use some other modality. This patient has very fair skin, so there's no need to treat the neck unless you wish to. So we've done one full pass in the lower face at 30 watts, 180 micron, SX of 8 or 2.5 millisecond pulse width. I've done a second pass periorally and could even do a third pass as needed. I've done a second pass to maximize tightening of the upper cheeks. And in the lower mid-face, we have some rhytids and volume loss. So let's do a second pass here to see if we can further tighten that area. And then we'll reevaluate it in 3 to 6 months and see if she needs any volumizing agent to add to the result. I'll do a third pass with the smallest square, which is usually very well tolerated, on the deepest lip rhytids. Again, it's not unusual for the patient to notice pinpoint bleeding, either intraoperatively or within an hour after the procedure. So it's usually typical for the patient to notice intraoperative bleeding, pinpoint bleeding where we've done multiple passes at the 30-watt fluence, or within an hour post-operatively. And that'll dissipate very quickly. This is the third pass at 30 watts on some individual deeper lines. So at the end of the procedure, we treat periocularly, and we always want to use protective lenses. We use a topical anesthetic such as tetracaine, a lubricant such as Lacrolube, and impervious contact lenses, not plastic, but non-reflective metal. So the topical anesthetic, I always warn patients after the procedure, their eye is still numb. It's possible for them to sustain a corneal scratch unwittingly because their eye is still anesthetized for a few hours after. So they shouldn't touch their eye for at least an hour after the procedure so as not to inadvertently scratch their cornea. So first we'll instill the tetracaine, and I warn them there's a slight sting. Can you open your eye? Now I'm just going to put a topical anesthetic. It'll be slightly stingy, and then the eye will feel nice and numb. Very good. A few drops instilled. We give that a moment. Contacts are protective to your eyes. You cannot see through them, which is helpful because it protects you from the laser emission. And you won't even know you have them in. Usually you can't feel or detect anything other than you can't see. So again, you cannot use plastic shields. You have to use frosted metallic shields that won't heat up or melt if the laser inadvertently touches them. We instill the lubricant, the Lacrolube. Usually distribute it. Apply the suction cup. Make sure that the tapered end is going medially. And I'll usually slide it under the upper lid first, as such. It's in, and then we can pull down either with our fingers or a Q-tip to clear the lower lash line, and it's in. Treat the periocular area. It's best to start with a 300 micron beam size. while I want maximal tightening, I'm going to switch to the 180 micron, but we're going to have to be careful to reduce the fluences and the density appropriately. So in this particular case, I'm going to choose an energy of 12 watts again, but I'm going to reduce the energy density to no more than 10%. And I'm going to do 1 or 1.5 passes. In this case, there isn't excessive eyelid skin. I'm going to choose to do only a single pass. The eyelids heal very quickly as long as you don't exceed safe parameters. That is to consider both your energy wattage and your energy density appropriately. And it's especially important if one chooses to use the 180 micron spot size. So I'm going to treat primarily the upper portion of the eyelid, and I'm not going to migrate down to the lower tarsal plate here. The upper eyelid will heal quickly, and there's no need often to treat the entire eyelid segment. When I use a relatively large square, the procedure goes quickly at this energy density of 10%. It's important when treating the lower eyelid, it is possible not to appreciate an ectropion from treatment while the contacts are in, but after they're removed, you may see the presence of excessive tightening of the lower lid and an ectropion. This needs to be assessed prior to the treatment. The patient's snap test is performed to ensure there's adequate elasticity. Consideration is given if they've had a previous blepharoplasty. Their lower lid will not be as resilient and should not be tightened if it had not previously had a surgical procedure or if it is excessively loose. Laxity is important to improve with the laser, but also has to be considered as it requires underlying musculature too to maintain the normal architecture of the eyelid. So if the snap test shows excessive laxity, energy densities need to be reduced greatly. And I'm going to choose not to go too close to the lower lash line, in this case because the eyelids aren't excessively lax. So you can see now with the contact lenses removed, can I have you open your eyes? There's no ectropion. Usually from excessive tightening of the lateral canthal aspect of the lower eyelid is where you're going to be most likely to create that ectropion. So as I said, it's important to assess the laxity and do a snap test of the lower eyelid before you start the procedure to enable you to determine your optimum treatment parameters. After removal of the protective contacts, usually the patient has blurred vision secondary to the ointment that we instilled. So we'll use a single-use hypotonic saline ophthalmic wash to rinse out the gel. Dressing, first we'll apply thermal spring water to cool the skin. This also eases the application of any topical. We usually dispense the patient the spring water to take home. And in my practice, I usually apply a single application of a class 1 topical steroid, such as betamethasone dipropionate augmented or clobetasol. This I find greatly reduces the postoperative edema and pain, and as a single application, I don't believe there to be any adverse effect on neocollagenesis. However, the reduction in edema and patient complaints of irritation are remarkably reduced just by this simple single application that the nurse can do prior to application of their dressing or their additional topical. Immediately post-op, after she's cooled down a bit, and the transient erythema and stinging sensation is abated, I'm going to apply, in this case, an anti-age MD serum as our first layer on top of the topical steroid. The next layer is going to be an occlusive dressing. In this case, we're going to use Stem Biogel, which is a vegetable-based, not petrolatum-based occlusive dressing that is non-comedogenic. Smooths on easily and is very soothing.